Reproductive physiology, pregnancy and changes. All right, so first off, we're going to talk about pregnancy. All pregnancy is that when we have the fertilization of the egg with the sperm, it's going to lead to a formation of the embryo, and then the embryo is going to implant into the endometrium. Once upon implantation, what occurs? We have production of beta-HCG, right? Once it sticks on day 6, right? We're going to produce beta-HCG by syncytial trophoblasts in order to maintain the corpus luteum so it doesn't regress. And so both beta-HCG levels are going to be really, really high, specifically. All right, and then we're going to have rising of levels of progesterone. All right, so very key concept, right? It's all about the implantation occurring on day 6, and then we have the production of HCG, which maintains our corpus luteum to produce our progesterone. After that first trimester, we're going to see a drop in beta-HCG because the placenta will take over in production of progesterone, so we no longer need the corpus luteum. And you will see continuous rises of estrogen and prolactin, as well as human placental lactogen. And we'll talk about HPL later on. All right? They love to ask about gravidity and parietal, all right? So the G's and P's of pregnancy. They will just give you that. It's going to be maybe helpful for some pathologies later on, and so I'll discuss it when we get to those specific pathologies. But all that they're talking about, G's is essentially how many pregnancies have they had, pregnancies, right? And then P's are going to be the number of pregnancies that actually resulted in a live birth, okay? So if you've had like 5 pregnancies, but you only have 1 child that was born, right, living, then you're going to have a total of G5P1, okay? All right, next is the physiological changes that we're going to see in pregnancy. This is very, very high yield. I cannot stress how important this is, okay? Because they love to ask it pretty much about every single question on this. Because pregnancy is relatively, it's a high output state. It's very stressful for the human body, right? You have to worry about it. You have to worry about pregnancy. So very important that we understand these physiological changes in pregnancy. Now, number 1, cardiovascular system. What happens? Well, we have an overall increase in blood volume, all right? And that's going to lead to an overall increase in cardiac output. Boom. First thing you have to know. All right, done. Right? Because you're dealing with blood from another baby, another human. So obviously you're going to have more blood within the body. And so then that's going to lead to an overall increase in cardiac output of the mother. All right? So that's one of the reasons, cardiovascular reasons. Next is endocrine. What do we see? We see an increase in insulin resistance and secretion. Okay? Now that's very, very important. We're going to talk about HPL later on, but that's very important. Next is GI. We see an overall decrease in GI motility, so patients can present with constipation during pregnancy. And we see an overall increase in the lower esophageal sphincter relaxation, okay? So the tone of the lower esophageal sphincter is going to be relaxed, and that leads to like an increased risk of GERD, okay? Next is hematological. Hematological is probably the higher yield of the pregnancy physiological changes. And the reason behind that is because it causes a dilutional anemia. Now, what does this mean? Well, we're going to have an increase in plasma volume. There's going to be more volume occurring, okay? And the human body's not stupid. It's going to increase its red blood cell mass as well. But it can't compensate for how much increase in plasma volume there has been. So even though we increase both red blood cell mass and plasma volume is increased a little more. So that means that we have a dilutional anemia. That means that there's not enough red blood cells that have increased compared to the amount of increase we've seen in the plasma. They call that a dilutional anemia because you've essentially diluted the amount of red blood cells. But don't get confused because they could ask you what happens to the red blood cell mass. And you might think, oh, the patient has anemia, decreased red blood cell mass in pregnancy. No, that's not the case. Remember, you're increasing red blood cell mass, but it just so happens that you have an increase in plasma volume that's more, so you can't compensate as much, so you still have a dilutional anemia. All right, so keep that in the back of your mind, very important. Another thing for hematological that they love to ask is that you're going to be in a hypercoagulable state. All right, so what does that mean? In pregnancy, we're going to be a hypercoagulable state due to the fact that it's such a hemorrhagic process. It's very traumatic for the mother to go through pregnancy. And so throughout evolutionary times, right, we've evolved because we're like, whoa, so many women have died from bleeding throughout pregnancy, traumatic bleeding. And so what we've evolved to is that we have now a hypercoagulable state during pregnancy so that we can avoid this bleed. But that's very important too because it could be pathological as well, this hypercoagulable state. It could be dangerous. So they could ask you about different levels of blood products that relate to hypercoagulability. One example I remember them asking about was like fibrinogen levels. And I never really understood what it meant, okay? So fibrinogen levels in a hypercoagulable state is going to be increased, right? It makes sense because we're ready to clot at all times. So fibrinogen is going to be ready to make a clot at all times. What about protein S? Protein C and S are going to inhibit our coagulation cascade. So we don't want inhibitory coagulation cascade because we're in a hypercoagulable state. So protein S is going to be decreased, right? So those are the things that you have to think about. All right. So in pregnancy, you have a dilutional anemia as well as a hypercoagulable state. All right. Next is musculoskeletal. You have joint relaxation. Okay. Because to get a baby through the pubic bone, it's very, very difficult. All right. So we have to have some type of musculoskeletal relaxant. And there's a hormone that they ask about. It's called relaxin, I think. It was like the weirdest question ever. That's why I remembered it. But keep that in the back of your mind. Next is renal. So what happens to the kidneys is that you're going to see an overall increase in GFR. Why? Well, because you have more plasma. If you have more plasma volume, that means you're going to have an increase in GFR, right? Because there's more fluid that you need to get rid of, all right? Or that you need to filter, I should say. All right. You're going to see an increase in basement membrane permeability as well. And so that's why you can have a potential proteinuria during pregnancy. And you could also have mild glucoseuria during pregnancy, which is both normal. It's physiological. All right. Very important. And then lastly, you have respiration. The respiratory system, you're going to see pregnancy causes a mild respiratory alkalosis. The reason behind that is because all of the CO2 and essentially all the toxins that are going to be produced by the baby and the mother, right? So you have 2 times the amount of waste being produced because you have 2 humans. You have to breathe them out somehow, all right? And because you have to breathe them out, you're going to be breathing essentially more. When you breathe more, right, chronic hyperventilation, that will lead to a respiratory alkalosis because you're hyperventilating, you're blowing off that CO2, and that leads to alkalotic levels, respiratory alkalosis. So keep that in mind. You have a mild respiratory alkalosis. Now, before I finish up with this conversation, I just want to talk about HCG as well as HPL, because I talked about HPL already. I'm going to kind of focus in on that a little bit. You're probably wondering, what the hell is HPL? This is the first time I've ever heard of it. Well, it's human placental lactogen. And the whole point of HPL, okay, this is all that it does, is that it promotes insulin resistance. So remember in pregnancy, physiological pregnancy, I talked about the endocrine system where we have increase in insulin resistance. That's secondary to the effect of HPL. The question is, why would I want that? Why would I want to have insulin resistance during pregnancy? Exactly. The answer lies in kind of the most obvious fashion. We want to get the most glucose to the baby because the baby needs so much glucose to grow, right? And so if I have essentially like my insulin working completely fine in the mother, she's going to take and store all the glucose. None of the glucose is going to go to the child. So HPL says, whoa. We're going to increase insulin resistance. So you're not going to allow to use insulin that much, right? You can use it a little bit, but we want to get the glucose to get to the child. Okay. And now that leads to, right, an increased risk for gestational diabetes. Okay. And so keep that in mind. If the mother essentially is unable to overcome this insulin resistance that's produced by the HPL, then that's known as gestational diabetes. Okay. That's all it is. Okay. That's the whole entire point of the process. That's what that pathology is listed for. Okay. If they can't overcome the insulin resistance that's provided by HPL, then they have gestational diabetes. All right. And the last thing is HCG, beta HCG. I've been talking about human chorionic gonadotropin so many times, HCG. Once again, the source of HCG is going to be the sincere trophoblast of the placenta, right? And the main function, as we talked about, is that it's going to maintain the corpus luteum in order for our progesterone to be produced from there, just for the first 8 to 10 weeks, right? For the first trimester. All right. Now, once again, they love to ask about essentially the differentiation between other hormones. So it has an identical alpha subunit as LH, FSH, and TSH, okay? So an increase in HCG can cause hyperthyroidism because it can act as TSH somewhat, okay? But that beta subunit is unique, all right? So pregnancy tests, they have to detect the beta subunit. That's why we call it beta HCG, all right? Now, also, HCG can be used in order to induce ovulation. Well, why would that make sense? Well, because they have the same alpha subunit as LH. So if we give them an injection of HCG, it can act as LH surge, leading to ovulation in people that are infertile. Okay, another small thing, right? Now, questions that they love to ask about, all right, is levels of HCG and how we can kind of determine what's going on within the pregnancy. If you have increased levels of HCG during pregnancy, it can indicate multiple things. It can indicate multi-gestation, so like you can have like twins or triplets. It can indicate hydatid-form moles, choriocarcinomas, and Down syndrome. Okay, we'll talk about those pathologies specifically each individually later on. HCG that's decreased than normally, okay, than expected. You can expect maybe an ectopic or failing pregnancy, and then Edwards syndrome and Patau syndrome also have those. All right, but overall, keep in mind HCG's effects, HPL's effects, as well as everything we discussed with the physiological changes in pregnancy, because those are the highest yield things that they love to ask about. That's all.